quick introductions. My name is Isabel. I'm the CEO and co-founder of GenerationMed. We're an organization dedicated towards medical education. So hosting events like this where you guys can connect with medical professionals and ask all the questions you have. Besides that, we are partnering this event with Cancer Kids First, an amazing organization dedicated towards helping the lives of children with cancer. And we're really great. We're really grateful to have Dr. Smith today.
Hello, my name is Thais Rowley, and I am the Chief Financial Officer at Cancer Kids First. And we are dedicated to helping children with cancer experience a better childhood through toy and book donations, as well as just supporting them emotionally. And I'm so excited to be here. So thank you for hosting this.
Thank you. So hi guys, my name is Jasmine. I am currently a third year. Oh, is that me? Oh no, okay. My name is Jasmine. I'm currently a third year pediatric resident here in Tucson, Arizona at the University of Arizona. In my last year of residency, I'm very excited to be starting my fellowship training in pediatric oncology hematology at St. Jude Children's Research Hospital in Memphis. So I'm happy to be here to talk to you guys about a few mini case studies of actual patients that I've seen throughout my residency, and then end it with a Q&A session for you guys to ask any questions about the cases, about medical school, about residency, about life, any questions that you might have. So we'll kind of jump into it. I have a few pictures here at the beginning. They're actually from like my Instagram stories, but I wanted to take some pictures on yesterday of the floor, the hemonc floor in the hospital, but didn't go to work on Friday. So I just found these pictures that I've put on my story throughout the time here. So this is the sign to the clinic that is also located in the hospital. This is inside of the clinic. They have a lot of very cute pictures kind of everywhere of different patients and kids that have been treated in the clinic. This was around Christmas time, as you can tell. And this is Gatsby. He's one of my favorite therapy dogs because he's huge and very loving. This was actually in the pediatric ICU during that rotation, but the hemonc floor is right past the doors next to the ICU, which is convenient. But the dogs are wonderful. The kids love them. They haven't been on the floor as much because of COVID, but hopefully that'll start returning soon. All right, and then we'll start with a brief overview of pediatric oncology. So these are just a few numbers as far as statistics about cancer diagnoses in children. It's the leading cause of death by disease past infancy for US children. However, because of continuing to better the therapies that we have for cancer, more than 80% of these patients are now long-term survivors, meaning they do well and they go on to be kind of monitored for years after therapy, because a lot of the therapies can cause kind of lifelong issues that they need to be monitored for. And then, of course, depending on the type of cancer, the survival rates vary. In adults with cancer, you think of adults getting cancer more from environment or lifestyle choices, but in kids, it's very unlikely that their cancer is caused by a lifestyle choice or their environment. Instead, there are many mutations that are usually the common cause of cancer in kids. Some of them just happen, and some of them kids are born with these genetic changes that increase their risk of getting cancer. So they either kind of have genetics already when they're born that increase their risk, or they have just kind of random genetic changes that can happen throughout life that causes them to get cancer. And here I listed the most common childhood cancers in order, leukemia being the most common, and then you have your brain and your spinal cord tumors, neuroblastoma, which is an abdominal, usually found in the abdominal area, Wilms tumor, which is a kidney tumor, found only in children, lymphoma, which can be found in kids and adults. Rhabdomyosarcoma is a type of muscle tumor that develops in the muscles. Retinoblastoma is a tumor that develops in the eye, in the retina. And then you have your bone cancers, which are the most uncommon, but a part of the common list of cancers in kids. And so those divide into osteosarcoma and Ewing sarcoma. All right, and then this is the first case. A lot of these cases, actually all of them are actually very recent patients that I've seen on the floor within the past few months as new diagnoses. So this first patient is a 2-year-old little guy, previously healthy. And I purposely used some medical jargon, and I'll explain what they mean just so you guys can hear them and get used to them. So he had a 1-week history of intermittent rhinorrhea, just meaning he had a runny nose, would kind of come and go for like the past week. He had some fevers, decreased oral intake, he wasn't wanting to drink, and also had emesis, or in other words, he was vomiting. He was diagnosed with an ear infection by his pediatrician and had just finished antibiotics a few days before presenting to the hospital. He was seen at his pediatrician, or PCP, which stands for primary care provider. You'll hear that term a lot as well. She went to the PCP one day before coming to the hospital because his symptoms weren't getting better. And he started having pallor, which means he started looking pale. And then he had decreased urine output. So mom took him to the ED because she was concerned and she wanted further workup for him. So in the ED, which stands for emergency department, you'll hear emergency department, emergency room, same thing. The vital signs were significant for tachycardia, just meaning that his heart was beating really fast. The rest of his vital signs, his respiratory rate, his blood pressure, his oxygen saturation, all of that was normal. He just had a really fast heart rate. On exam, again, they listened and they heard that his heart was beating really fast. They saw the pallor, or the paleness of his skin. And then when they were feeling on his belly, they felt what's called hepatosplenomegaly. It's a long word to say that the liver and the spleen were both enlarged, and so they could feel them on exam. Normally, you shouldn't be able to feel them, but they were big, so they documented that they felt that on exam. The labs that they obtained were significant for anemia. So the hemoglobin was 3.3, meaning that the red blood cells in the blood were low. Thrombocytopenia, platelets were only 27,000. Normal platelets are between 150,000 to about 400,000. So low platelets, which are the cells in your blood that help you to clot. And then leukopenia, so white blood cell count was low, it was 3,000. So normal white blood cell count is around like 4,500 to around like 12,000. So leukopenia, meaning the low white blood cell count. And the white blood cells are those cells in your body that help you to fight infection. Elevated inflammatory markers, so the ESR or the sedimentation rate and the CRP are both just markers that let you know that the body, there's an inflammation going on in the body, whether that be from an infection or some sort of disorder that's just causing the immune system to go into overdrive. But both of those were elevated for this patient. And then he was also positive for rhinovirus on the viral respiratory panel. And that's a swab that we do of the nose. And it tests for a list of different common viruses that can occur. And he was positive for rhino, which is just the common cold. Everyone likely has had rhinovirus in their life because it's very common. So with those labs, fast heart rate, he's pale, his liver and his spleen are both enlarged. He has what we call pancytopenia, meaning that all of his cell lines are down. So his red blood cells with the hemoglobin, his platelets, and then his white blood cells are all low. So we call that pancytopenia. Elevated inflammatory markers, and then we know that he has a virus. So with all of that in mind, this whole picture makes you think of leukemia. And so in this patient, all these pictures of these kids are from the internet. This is not the actual patient, but leukemia presents, that's a very common presentation of leukemia. You have kids, they come in, they haven't been feeling too well. They may have had a recent illness. And when you check their labs, either 1 or 2 or all of their cell counts are down. And that's concerning always for leukemia. And the next slide will kind of explain why that's concerning for leukemia, but it's the most common cancer that's diagnosed in kids. It's usually diagnosed between 2 to 5 years of age, slightly more common in boys than girls. But the overall cure rate for leukemia is very good, it's greater than 80%. And these children usually do well if they don't have a high risk type of leukemia. And so I threw this in here. This is a chart that you will definitely see in medical school. And it just gives you a breakdown of the cells in your body. So your white blood cells, your red blood cells, and then your platelets. And so you start out with this one stem cell that then divides into the lymphoid side and the myeloid side. And so with leukemia, you can have a lymphocytic leukemia or you can have a myelocytic leukemia. The most common type in children is the lymphoid type, but they can also get myeloid type, which is called AML versus ALL, which you'll hear those terms as well. So on this side, for this patient, he ended up having B-cell leukemia. And so the lymphoid side breaks down into a lymphoblast, which is like the baby cell that's going to further divide into either a B cell, a T cell, or a natural killer cell. So you can have a B cell leukemia, you can have a T cell leukemia. Again, the B cell is the most common type of leukemia, B cell ALL. So that's what this patient had. He had an overproduction of these cells, the abnormal cells. And so if you go on this side with the myeloid cells, out of this comes your red blood cells, which we talked about when we talked about the anemia and the hemoglobin, the platelets, which we talked about when we talked about thrombocytopenia and him having the low platelets. And then the myoblast further divides into these three different cells, which are also cells that your body uses to kind of fight infection and lets you know if the body's inflamed. And so these cells, usually you won't see a cancer that's strictly these cells. But you can have it here where you have the myoblast is usually where you have the disorders, where this is where you'll have the division and not down here. So this is just a nice picture, and I just found it, you can find it anywhere on Google, but it gives you a nice breakdown of what your body is making from your stem cells. And so all of this is happening in your bone marrow, is where these stem cells originate. And so when patients come in with this cell line down, this cell line down, all of these cell lines down, it's because the bone marrow is so filled up with all of these rapidly producing cells that it can't make these normal cells. So then these numbers end up going down. And that's what we saw with this patient. And then feel free to stop me if you have any questions. I'm just going to keep going through them so we can have some time at the end. So the second case is a 3-year-old girl. Is coming in here with a history of constipation, presenting with this 5-month history, so a long history of this worsening constipation, abdominal pain, and also abdominal distension, just meaning that her belly was getting bigger and bigger and just looked swollen. Mom had taken the patient to multiple PCP, again, primary care provider. In this case, for this patient would be a pediatrician or a family medicine doctor. So took the patient to the PCP and to urgent cares multiple times for these symptoms over the past few months. And every time, they kind of attributed it to her constipation as to why she was having these symptoms. So mom became frustrated, and she said she took the patient to the ED because she wanted to get a further workup, and she wasn't happy with the answers that she was getting from the other providers. So for this patient in the emergency department, her vital signs were completely normal. So her heart rate was normal, respiratory rate, her blood pressure, and then her oxygen saturation. She was breathing fine on room air. On her exam, they felt a large palpable, meaning that you can feel it, abdominal mass that was extending from the left side of her body kind of to the midline of her body, kind of all the way across. So pretty big mass. But it didn't seem to hurt her. So it was non-tender to their palpation. She didn't seem to be in pain with that. And they were feeling this mass on previous exams at her PCP's office and at the urgent care. But they, again, were attributing that to like a stool ball, which does happen in kids if they're very constipated. So they didn't really think anything of it at that time. They did labs for her in the ED, and those were significant again for an anemia. Her hemoglobin was 10.8. Which was mildly low. And in kids, it kind of varies by age as well. So that's the other thing in pediatrics, is these labs kind of change based on the age. But for her, this is like a mildly anemic, nothing too crazy. And then she had an elevated LDH, which stands for lactate dehydrogenase. It's a very non-specific test, but when it's elevated, you get concerned for inflammation, you get concerned for a lot of cell breakdown because this is kept inside of your cells. So when you have a high LDH, you worry that your cells are breaking open at a really fast rate. And that's something that can happen in cancer, something we call tumor lysis, when a lot of the cancer cells start breaking open and releasing all of these elements. So her LDH was very elevated at 786. They also did imaging for her because of this large mass that they felt in her belly. And so they did a CT scan or a CAT scan, and it showed she had a large mass originating from the left kidney, crossing the midline and extending. So from the diaphragm, which is like right below your ribs, all the way down to the pelvis. And it also showed on that scan that she had 2 nodules or 2 small little masses in her right lower lobe of her lung. So in this patient, any patient this age, a large abdominal mass, you get concerned about either a Wilms tumor, which is the kidney tumor, or you get concerned about neuroblastoma, which it forms from the neural tissue that can develop kind of anywhere along where you have neuron tissue. But the most common area is in the abdomen from the near the adrenal gland. And so in this patient, it was coming from the kidney. So she had a Wilms tumor. And this is just a random cutie from the internet. But it's the 4th most common type of childhood cancer. It's the most common kidney cancer in kids. Kind of similar to leukemia, it presents very early on, usually between 2 to 3 years of age, and then boys and girls are equally affected. If they have favorable histology, meaning that when the pathologist looks at the sample, the biopsy of the mass, under the microscope, if they have tissue that is favorable and basically a lower risk, then their rate of cure is 85 to 90% of those patients are going to do fine. And of course, that's a little bit lower if they have tissue that is considered a little bit more high risk. And you can see his little scar there from most of these kids get either, if they can't get the mass, like a clean margin of removing tumor, then they end up having to remove the whole kidney. So most of these kids end up just having 1 kidney, which is fine. You can live with 1 kidney, but then they end up having complications, sometimes such as like high blood pressure when you just have 1 kidney.
Hi, I had a quick question before we moved on. So
Yeah.
in case 1 and case 2, it seemed that so when the children were diagnosed with their primary care physician or a pediatric doctor, parents ended up being frustrated and taking them to the emergency doctor. So I wanted to know, is it a common occurrence for children to be underdiagnosed by their primary care physician?
It's a very good question. I won't say it's common, but it's very easy. And I try to kind of see it from the perspective of the pediatricians as well, that cancer is such an uncommon thing in kids, even though we're kind of talking about it now. And for me, it's going to be a very common thing because that's what I'm going to do with my life, but it's very uncommon. And so a lot of the times they like to go through kind of all of the common things first before they go down the route of saying maybe this is cancer. In this particular case, I'll actually share. So we do things called mortality and morbidity conferences. And I think all specialties kind of do it, but it basically, you go over a case where you think something didn't happen the way it should have happened. You felt like care could have been carried out better. So mortality meaning either the patient died because of this, or morbidity meaning they just had, a delay in diagnosis, a delay in treatment. And the point of it is not to point fingers or make anyone feel bad, but it's to go over, what could we have done better? What can we learn from this so that we can avoid it in the future? And so this particular patient was used for one of those conferences. And the idea was that common things being common, yes, constipation can cause abdominal pain. It can make their belly a little big, but she had been seen multiple times by the pediatrician, by urgent care, and everyone just kept saying constipation because that's what was in her chart. Everyone was like, well, it's just constipation. So it's definitely one of those things where you have to, as a primary care doctor, just always keep it in the back of your mind, even though it's less likely that will actually be the answer each time that the kid has cancer. But it's something that you should always think about, because if you don't think about it, then you're not going to test for it. You're not going to really look for it. So it's just something that's hard to, And I'll talk about that too with one of the other patients, but it's hard. It's very hard. But as long as you're thinking about things, and that's just kind of what I've learned in residency too, like even if it's not the most likely thing, at least you think about it and you have it in the back of your mind so that if things don't progress, if things don't get better, then you can say, okay, now it's time to like think of the uncommon thing since this common thing is not getting better, if that makes sense.
Of course. Thank you so much.
Yeah. Anybody else while we're paused? Okay. All right. And then this is just a CT scan of an actual Wilms tumor that I also got offline. It's not the patient's. But just to give you some direction here. So this is the right kidney. This is a normal kidney. And then you have this giant mass over here that is not normal kidney. You can't even really see where the normal kidney is, but you just see that, you can see that kidney, and then all you see right here is the mass. And then this kind of edge right here would be the liver. And I want to say this might be the pancreas or the spleen. I'm actually not too sure, but I know that this is liver, this is kidney, this is the spinal cord, your vertebral column, and then this is the giant mass. All right, case number 3. So we have a little bit of an older kid, a 15-year-old guy, previously healthy, presenting with this right distal, just meaning lower thigh swelling and pain. He first started having the pain back in 2019, went to go see a doctor, didn't get any imaging or any labs done. And they said, you know what, it seems like growing pains, which is something that is a real phenomenon in kids. As they grow and get bigger, as the bones divide more and they just start to get taller, they can sometimes have pain in those bones that we call growing pains. So this is what the doctor told him that he had at that time. So then he developed some worsening kind of swelling in 2020, so in late 2020. He was evaluated again at that time, and this time they did do some imaging, so they did an x-ray. And it showed that he had a mass of that distal femur. So your femur is that big bone in your thigh. So he had a mass kind of at the lower end of that on his right leg, like right above his knee. So they recommended he get an MRI because that would be a better test to kind of see exactly what type of mass this is, whether it was a benign mass or whether it was malignant. The patient never got the MRI. It sounds like he just kind of didn't get it, got lost to follow up. But then he came to the emergency department because he started having worsening symptoms a few months after he was told to get the MRI. So in the emergency department, his vital signs were normal. So heart rate, respiratory rate, oxygen saturation, and then blood pressure were normal. On his exam, they did note that they could feel and see a firm mass in the right lower femur, mildly tender. So it hurt a little bit when you pressed on it, but it wasn't too bad. They got labs, kind of the routine blood labs to check his hemoglobin, check his white blood cells, platelets, electrolytes, all of that. And all of that was normal for him. They got another x-ray at this ED showing the mass again. And so at that time is when they ordered the MRI. He got the MRI done and it showed a large mass again originating from the distal femur, concerning for osteosarcoma. And so in this patient, it's very common for the solid tumors, especially the bone tumors. The kids present otherwise fine. Vital signs are normal, their labs are normal. All they really have is kind of this pain. Sometimes they don't even have swelling. So they just have a pain of their leg that doesn't really seem to get better or worse with anything. It's just there. And then they get imaging and it shows that they have a mass there. So osteosarcoma. So this is actually my brother, and I know I shared in the bio about him. So he had osteosarcoma of his right leg, and this is his scar. It's the most common type of bone cancer in children and in teens. So this usually occurs in older kids, typically after 10 years of age, slightly more often in boys than in girls. If it's localized, meaning that it hasn't spread to other areas of the body, it's just right there in that bone, and they're able to get it out, cleanly get it out, and they go through kind of chemo and everything's fine. Long-term survival is still not that great. It's only 70 to 75%. So if they've already, at the time of diagnosis, if they've already had kind of spread to the lungs, they already have nodules there, or they have other bones that are also diagnosed with osteosarcoma, then the survival rate drops to only about 30%. So this cancer is very much so not, it doesn't have a great survival rate. Even if everything's perfect, it's only 70 to 75%. And so, and in this patient, I forgot to mention, he did have, I don't think I put it in there. He did have imaging of his chest as well, because this cancer, when it spreads, it commonly spreads to the lungs. So they did do that initially just to see if he already had disease. And he did have 2 small nodules in his lungs that were concerning for already having kind of metastasis or spread to the lungs. So it has a horrible survival rate. This is the field. Sarcomas is what I'm primarily hoping to focus on. Once I'm done with fellowship, and during fellowship, I want to be trained as just a sarcoma doctor, because of course it's near and dear to me, and the treatments and everything are just so far behind all the other cancers for kids. And so I really want to see these numbers get so much better, because it's a horrible disease, and a lot of the kids do present already having pulmonary masses. So
I have a question. Oh, sorry.
Yeah, sure.
How long or like how fast does this tumor spread? Or like how long does it take before like it's dangerous?
Yeah, so if they present and they don't already have spread, usually they go through surgery, they get the mass removed, and they also get chemotherapy, because they're always, you never know if there are always a little bit of kind of cancer cells lingering around in the blood. So I would say it really depends. Some kids can show spread of disease after like their first round of treatment. Some kids can show return of disease after like a year post-treatment, which is kind of like my brother. Like he got, the mass removed, he got chemo and everything, and then he got his like routine checkups to monitor for any spread, and he was okay for about a year, and then that's when they started seeing the nodules in his lungs. So it kind of varies. But these kids get close follow-up. All of the cancer patients, kids and adult, get kind of routine follow-up even after they go into what we call remission, or the sign that we don't see any more disease, because it's always possible that it could still develop later on.
And is there any like specific symptoms? Because like if you like you have pain somewhere or something, you could mistake it for something else. Is there like a specific symptom?
There's not, and that's what makes this one hard as well, because I will say my brother, I'm sure my mom took him to the doctor, I want to say like 2 or 3 times before they actually imaged his leg and found the mass, because again, they were like, oh, with his age and he's tall, it's growing pains, it's likely growing pain. So it's one of those things where, again, if you don't think about it, you're not really going to look for it. And so that's really all they have. Sometimes they just have pain. He just had pain. He didn't have anemia. He didn't have fatigue. He wasn't pale. He wasn't having night sweats. It was just the pain. And so these are usually pretty hard to catch if you're not thinking about it, because you don't want to just x-ray every kid, because then that's just radiation. But if the picture fits with the age group, the pain, like where the pain is, normally is in the lower leg, kind of around the knee, then you kind of have to think about it and just get the imaging just to be sure. But there's no, and I understand your question, there's no like pinpoint symptom that's going to make you think this is osteosarcoma. You just have to put the pieces together, localize kind of where the pain is, the age of the patient, and if it fits, then you just look for it if you're concerned.
I have another question.
Yeah.
So you said that you went to specialize in sarcoma specifically. So there is a way where you can specialize in one specific form of cancer, like leukemia, or like you said, sarcoma. So is there a way that you can specialize in that? I know it takes years, but I just wanted to clarify.
Yeah, you definitely can. You would likely have to go to a very large institution in order to be very specialized. And so that's why I'm really happy and excited I got my top choice at St. Jude, because I know there they have people that are very specialized in specific areas of oncology and hematology. So you can decide, like once you're in fellowship, you can say, well, I have a particular interest in leukemia. So I just want to take care of leukemia patients. That is something that you can do. You just have to plan it out really well and make sure that you're at an institution where you will have that flexibility to say, I only want to do leukemia. So, because if you go to a smaller place, kind of like my institution here, the doctors here are kind of general pediatric hematologists, oncologists, meaning they see everything, because they don't have enough doctors, they don't have enough kind of patient flow to say, I'm only going to see these types of patients. So you have to go to a pretty big hospital, but it's definitely possible.
Thank you.
Mm-hmm. All right. And then this is just an X-ray of what an osteosarcoma looks like on X-ray. And it's a very common question that we get on exams, differentiating this one from Ewing sarcoma because they look different on X-ray. But the common description of osteosarcoma is this kind of like sunburst pattern that you'll see coming from the bone. And so this is a lateral side, or you're seeing kind of the side of the leg, and it, you can still see the sunbursting of the bone. And again, this is your femur, so they usually kind of present in this lower femur part, but they can also present, this is your tibia, they can also present at the top of the tibia. So it's always kind of, or usually kind of around the knee. But you can also get it in the shoulder. I haven't seen much of that. All of the sarcomas I've seen in med school or in residency have been around the knee. All right, and then this is the last case that I have. So this is a 20-year-old, getting older as we go, 20-year-old female, previously healthy. She's coming in with a 1-week history of left-sided pleuritic pain, meaning that when she breathes, she's feeling kind of pain in her chest, which we call pleuritic pain, because that usually means that there's some sort of like inflammation around the sac that the lungs sit in, so that when you breathe, you have a pain. So she only felt it when she took like deep breaths in inspiration, but otherwise she was not having any chest pain or any other concerns, except for a dry cough for about 2 days. She noticed that she was feeling fatigued or a little tired at her birthday party a couple days ago, but otherwise has been feeling normal, has had normal energy. And then all other review of systems are negative, just meaning that we kind of asked everything kind of head to toe, skin questions, abdominal questions, lung questions, heart questions, and all of that was negative, except for what was mentioned here. So she came into the ED because of this sharp pain that she was feeling when she took deep breaths in. Her vital signs when she came in, she was tachycardic, so her heart rate was beating pretty fast. Heart rate was 140. Normal for her age would be around 60 to 100. And then hypertension, just meaning that her blood pressure was really high. So it was 143/88, with anything over 120/80 being considered elevated blood pressure. And then her exam, again, was significant for tachycardia. Her heart was beating fast when they listened. She had diminished breath sounds. So her breath sounds, they were very soft. They were very low. They couldn't hear them that well. In the front, on the side, and on the back of the left side of her body. So her left lung seemed to have lower breath sounds compared to the right side. Labs that they obtained, again, the routine kind of blood labs were all normal. They got imaging. So this is in the ED, and sometimes they do bedside ultrasounds when they can. And in this patient, they did a bedside ultrasound of her chest because they were concerned about the decreased breath sounds they heard, and then also the fact that she's having this pleuritic pain that seems to be related to her breathing. So they did an ultrasound right at the bedside of her chest, and they saw a moderate to large pleural effusion on the left, meaning that, so your heart, your lungs, and your heart both have a sac that kind of sit around it to kind of protect it. And a pleural effusion is basically there's fluid between that sac and the actual lung tissue, which can develop from infection, it can develop from cancer, it can develop from a few other reasons, but she has some fluid in there on the left side. And so that would explain why she's having a little bit of diminished breath sounds, because she has fluid in there that's kind of interfering with you being able to hear her breathe. And then they obtained an X-ray showing an anterior mediastinal mass versus lung mass. They weren't able to determine on an X-ray because it's not the best study to kind of differentiate. But anterior mediastinal, meaning it's in the front, and it's right in the middle. It's in that mediastinal area. So they think it's there, or they think it's originating from the lungs. They're not sure. So they decide to do a CAT scan or CT. And so the CT shows, again, this large anterior mediastinal mass. It confirms that it is in the mediastinum and it's not coming from the lungs. And then it also shows that she does have two small pulmonary nodules, or small little masses, kind of at the top of her left lung. So in this patient, you get concerned for lymphoma. Her age, the location of the mass, her symptoms, they all kind of fit with lymphoma. Normally, these patients have a lot more. They have fatigue. They usually have chills. They usually have night sweats, but it sounds like her presentation was pretty mild. You have Hodgkin and you have non-Hodgkin's lymphoma are the two main groups. So if it's not Hodgkin's, then they just consider it non-Hodgkin's. And there's a lot of different subtypes of non-Hodgkin lymphoma. Hodgkin lymphoma only has 4 subtypes. So that makes it a little bit easier to remember them. Non-Hodgkin accounts for about half of the childhood lymphomas that you see. It's much more common in boys than girls. And then about 80 to 90% of patients are cured. So it's actually a very curable cancer that develops usually kind of in that teenage, young adulthood type range. And it has Hodgkin's, so I think that was for non-Hodgkin's, sorry. Hodgkin's has an even better survival, about 90 to 95%. So they're both fairly curable cancers that patients usually do really well with. I found this picture and thought it was a good one to show. These nodules that they're highlighting here are basically very enlarged lymph nodes. So lymphoma is a cancer that develops within the lymph nodes. And these patients also usually present with some sort of large lymphadenopathy is what we call it, or just some sort of pathology happening within the lymph node. And sometimes that can happen just when you have an infection, your lymph nodes can get really big. But the thing you worry about in this age group, and then especially if it doesn't hurt, it's not moving, it's very still, you think about cancer. When it's infectious, it's usually red, it's usually swollen, it's usually painful to touch it. And it usually moves a little bit, but in cancer, it's very stuck, it's hard, it doesn't hurt them. And that kind of makes you kind of differentiate from the two. And then.
Hi, sorry to interrupt.
Sure.
I just have a quick question. I know this patient you said is 20-year-old, and you mentioned that you focus on like pediatric cancers. So why would you be seeing 20-year-old patients in your area?
Yes, great question. So we've actually taken care of older patients, but usually, so we say pediatrics is like usually you're 18, once you're above 18, you're kind of on the adult side. But we actually see up to age 21 usually on the floor, and then also in clinic. In pediatric oncology and hematology, it can get even longer than that. Sometimes a lot of the like lymphomas, leukemias, they can present kind of in those older kind of teenage, young adult ages. And usually once they're established with us, we kind of manage them throughout the rest of their treatment. And they usually feel comfortable just going back to, their original doctor that diagnosed them, and that has been helping them. We have had patients in the hospital that get diagnosed with cancer, like they were on the adult floor, they get diagnosed with a leukemia, but they're like 22, 23. So they'll actually transfer them to our floor because leukemia is still kind of considered, especially in that age, a pediatric cancer. And so they get sent to us because we do tend to take care of patients kind of into their like early 20s. Diseases like sickle cell, I know this is oncology, but on the hematology side, sickle cell is one of those diseases that also kind of transcends from childhood into adulthood. And so we usually end up seeing patients up until like their mid-20s. Sometimes they'll transition to an adult specialist, but most of the time, honestly, because pediatric doctors are so great, they usually stay with their pediatric oncologist. But that's a great question.
Thank you.
Yeah. And then I think I just have a picture of the mass. So this is also a common presentation of lymphoma. And anytime any patient presents with any sort of concern for cancer, you always get a chest x-ray because there's always the potential that there's a mediastinal mass there. And in this patient, this mass is like basically a giant lymph node that has become this giant mass, giant tumor in the chest. And that's just a common area for the lymphoma to develop. And then you can also see this with T-cell leukemia. We talked more about B-cell leukemia because it's the most common, but specifically for T-cell leukemia, they also present with a mediastinal mass. So usually those patients, all the patients get x-rays, but when you see that and it's a leukemia, then it's most likely going to be a T-cell. But this is just a good depiction of how big the mass is. And so you can understand why she's having fluid kind of in that sac, why she's having trouble taking deep breaths in, and why the breath sounds were kind of diminished because it's kind of being taken over by this mass. And then this is just a lateral or side view of that mass as well.
And I think Varisha raised her hand.
Oh yeah, sure. I think that was my last, yeah.
Varisha, did you have a question? Well, she did leave in chat. I think it was for case study number, Yeah.
Sorry, I was gonna ask, what's the main difference between pediatrician and adult doctors in terms of cancer?
So in terms of cancer, so there are, I would say leukemia and lymphoma, and even like the bone tumor sarcomas are the three that you can see in both groups, but there are cancers that you only see in adults and cancers that you only see in kids. So in kids, one of the ones we talked about, Wilms tumor, strictly a pediatric cancer. Neuroblastoma is also strictly pediatric. Retinoblastoma, or a cancer of the retina, that is also, you only see that in kids. In adults, things like pancreatic cancer, breast cancer, lung cancer, those are primary cancers that you don't see in children. So there are just a few that are strictly pediatrics and strictly adult, but then you have the leukemias, the lymphomas, and then the bone tumors that can kind of muddy the lines a little bit.
Thank you.
Yeah.
And I guess with everyone raising their hand, we'll move to our participant Q&A session,
Yeah,
starting with those who have their hands raised, and then moving over to chat. So also let's try and keep it about pediatric oncology for a little bit, then we can transition to, I guess, more personal questions. So Lizette, would you like to start?
Yes, so I know how hard it is for the parents to, see their child go through cancer. So how do you manage, or are there any courses that you take, since I know you're in residency, to help deal with the parents, with their opinions, as well as trying to help find a cure or, make the child feel comfortable in their situation?
Yeah, good question. We do get trainings, not very often, but we do get trainings on how to deliver bad news, like the best kind of setting and the best kind of way to say certain things that are going to be devastating to a family. And so the biggest thing in that instance, especially when you're initially telling them, is to not talk. Like you tell them the news and you kind of just be there. You let them respond with whatever emotion, whatever, speech, whatever talk, whatever they want to do to kind of react to that. Because throwing a lot of information at them, especially in that moment, they're not going to remember anything. They're just going to remember that their kid has cancer. So everything you say after that is kind of, it doesn't matter. They're not going to hear it. So in those initial moments, you kind of just have to, give them, don't sugarcoat what the diagnosis is, tell them exactly what it is, and then give them that moment to react. And honestly, a lot of the times it's your role as a physician is just to sit there and listen to them. And if they ask you a question, respond. But a lot of it is just sitting, listening, not trying to take control of the conversation, not trying to give them more information than they can handle in that moment. And so it becomes this, over time, you develop this very close relationship with the family. And that's another reason why I really love pediatric oncology, is that you develop this almost family-like relationship because you see them all the time. You're there for their worst moments, you're there for their best moments. It honestly becomes a very family-like thing. So it's so important in the beginning to kind of establish a good relationship, a good rapport with the family, so that as things go on, they'll trust you to give them all the information. They'll trust you to be there. They'll trust you to listen to them, because it's not ever going to be an easy conversation to have with families, and it's never going to be a perfect conversation or something that you'll just, always nail it and get it right every time. But if your heart is in the right place and your goal is to tell them, educate them on what's going on, but also allow them to have the space to kind of get their feelings out, express their concerns. Some families don't want to do chemotherapy. And as much as, we want them to, and we're saying this is the best bet for your child to get cured, it's ultimately it's a partnership. You give them the best information, and then they make the decision of what they want. And so, not judging, not pushing things onto them, and just kind of having that open dialogue all the time, I think is what's really important as far as providing the best care for those patients and their families, because the family really does, it's everyone kind of going through it and not just the patient. Of course, the patient's taking the brunt of it, but the whole family is affected by it.
Thank you.
All right, and then next, Sydney.
So I noticed a lot of, majority of the cases you showed us, they were, like you said in the beginning, childhood cancer is mostly genetic. So I was wondering what your opinion was on like gene editing and the technology like CRISPR.
Yeah. So in CRISPR, I know for sickle cell, a lot of the disease, especially sickle cell, where we actually know like the gene and know exactly where the problem is, coming up with gene therapies to kind of alter that or modify that in some way so that patients don't actually get the disease or don't actually have the symptoms, I think is wonderful. And there's a lot of that going on within the oncology field as well. It's just a lot harder to kind of isolate specific genes because it's really random in kids. Again, there are some that are born with specific genes that we know increase the risk for cancer, but a lot of them have just random mutations that occur that we aren't able to truly isolate. But there are a lot of, not necessarily gene therapy, but immunotherapy that's developing in cancer. And they basically create these antibodies, specific antibodies that are programmed to attack a certain cell or a certain kind of protein or anything on the cell that we know is related to the cancer. So then the antibody can kind of attack that part of the cell, but nothing specifically like gene therapy related for cancers quite yet. There are the genes like in adults for like breast cancer, there's the BRCA1, BRCA2 genes. So we know that those genes are known to have, those patients who have those are at an increased risk of getting breast cancer. So I want to say, I don't want to misspeak, but I'm sure they're moving towards like gene therapies for those particular patients. So in the situations where they know the actual gene or they can kind of isolate where the issue is, I think it's wonderful if we can create therapies for that. But for a lot of the like childhood cancers, we just haven't reached that, have that ability quite yet. A great question.
Since you said that most cancers like spread because of, or like childhood cancers because of genetics, is there any like prevention?
Also a great question. No, and that's what makes it hard, right? So we tell families like it's a random genetic some sort of mutation that happens that we don't know what it is, we don't know why, but it happens. And a lot of the times, especially in the beginning, when you're telling a family that their kid has cancer, the parents think of ways to blame themselves, or they try to think of a way they could have stopped it or something. And we always have to tell them there is nothing that you did or didn't do that caused your child to develop cancer. And so that's something big with counseling that we focus on, is telling families like there's nothing you could have done. This happened randomly. We do not know why. And it's, that's where all of the money and kind of research is going, is to kind of figure out why these mutations are happening, where they're happening, and how we can prevent them. But at this time, there's no data to say that there's one thing or anything that can prevent a lot of these pediatric cancers from happening.
And then next with the raised hand, Nidhi, would you like to go?
Thank you. So I have a personal experience of someone in my family having cancer, and it was so hard for them to go through chemo, and they were an adult. And I was wondering how can you take care of a child going through something like that? Is it harder or is it easier for them depending on their immune system or whatever happens? So do we use the same chemotherapy?
Yeah, good question. So a lot of the medications are used in kids and in adults. Of course, the dosing and everything is very different because it's based on like body weight, body surface area. But a lot of the drugs are very similar. There are some medications that are used in adults that aren't used in kids. Usually, really with any pediatric field, medicines that are kind of new and brand new that are being used in adults usually don't start being used in pediatrics for years, just because there are trials that they also have to go through with kids to see if it's actually safe for kids, because a lot of there are some medicines that are safe in adults but not necessarily safe in children. So a lot of the medicines are pretty similar, especially the older chemotherapies that we know that we already know work in children and can be given safely. But I would say, as far as like treating the kids and how they respond, kids are so resilient. And that's another reason I really love pediatrics, is that kids, they can come in super sick, they can be super sick one moment, and then the next minute they're like playing on the tablet and eating chicken nuggets, and they're very resilient. I will say that they don't complain a lot. They have to really be hurting or be in pain to usually say anything, or usually have an interruption in like their kind of day-to-day activity. So that makes it easier, I think, in my mind, with pediatric cancer, is that the kids themselves, they could be going through chemo, they could be bald, they could have all these lines in, but they're still smiling, they're still playing. And we make it a point in pediatrics in general to make kids feel comfortable, make them feel safe. There are child life specialists who are wonderful, who work in the hospital, who help when kids have to get certain procedures done, if they have to get an IV, if they have to get an NG or like a feeding tube in, the specialists worked with them to kind of explain it to them at their developmental level. And they're there to provide kind of extra support with toys, with music, with whatever they need to do to kind of distract the child and kind of make them feel at home. The therapy dogs are wonderful. Pediatric floors in general are just very colorful, they're very fun. There's always something exciting going on, especially on the oncology floor. So we make an extra effort to make sure kids are still able to be kids even when they're in the hospital.
Okay, thank you.
Mm-hmm.
And a couple more raised hands. Let's go with Anya.
So I had a question regarding the most common childhood cancers that you see that are most prevalent. Are these the most common cancers due to developmental growth? We see children usually up to the ages of like 25, or like you said, young adults, growing a whole lot more than you would see in adults. And do we see a whole lot of cancers that have to do with developmental growth because of more cells that are being created simultaneously in growth? Like, does that equal a higher risk for overproduction of cancer cells, is what I'm trying to ask.
Yeah, no, good question. I think I got what you were saying. That's a good question. So I'll say in sarcomas specifically, the bone tumors, with them happening around kind of like that teenage age where most kids are having like their growth spurts and their bones are just rapidly dividing, that is thought to be one of the things that increases the risk of them developing those bone tumors, is because they're having kind of that rapid cell division, and sometimes that can get out of control, and then they develop this mass. So that is one of the thoughts. And with a lot of the cancers, like you mentioned, like the Wilms tumor, the retinoblastoma, a lot of those occur during kind of that young toddler age. where a lot of cells are dividing, a lot of cells are immature and kind of making their way to maturity. So there are thoughts that whole process of development and kind of things still being a little bit on the immature side can lead to some of the cancers that are, especially the ones that are primarily pediatric, because we don't see the Wilms, we don't see the retinoblastoma in adults, and that it could be linked to that process of having kind of rapid cell turnover from growth. So that's a great question. There's no like official data to say one or the other, but it is thought to be one of the things that could potentially be the increased risk for kids.
All right, great.
Thank you.
Thank you. And then next, Chandini. And also, we're getting upon that 1 hour mark. If you guys need to leave, you guys can feel free to leave. Again, we will be recording this and posting this on YouTube for later, and you'll get a link for that afterwards. But without further ado, Chandini, would you like to go?
Hi, I was just kind of wondering if you could kind of go over the actual process of like becoming a pediatric oncologist, like what actually happens in like high school and then in pre-med and then medical school, stuff like that.
Yeah, for sure. So high school, so I knew I wanted to be a doctor since like middle school, but pediatric oncology wasn't on my mind until my brother got sick. So in high school, I did a lot of the I don't know what they call them now, but they called them AP classes when I was in high school, for biology, for chemistry. I kind of tried to get a lot of that early exposure while I was in high school before going to college, just so that it wouldn't be such a big change for me in college. I didn't have really I didn't know any doctors when I was kind of going through high school, going through college. So I didn't really have anyone to kind of talk to about the process. I kind of figured it out as I was going along. And then when I went to college, so I went to school at Spelman in Atlanta, and they have a pretty strong science department, a pretty strong kind of pre-med healthcare program there. So that really helped me to get exposed to actual doctors and to actually meet people that have gone through what I wanted to go through, so that I could actually talk to them and get advice as far as what classes I needed to take in college and how I needed to prepare myself to actually get into medical school and going forward. So I would say at your college, making sure that you get plugged in, and even if your high school has it, I don't know if there are many that do, but most colleges will have kind of a pre-med or a pre-health professions type program. Strongly advise getting involved with that during your first year, when you first get there, so that they know you, so that you can get well established with them and can kind of start prepping early for your medical school application at the end of college. So that would be my first recommendation for that. You would also need to get some pretty decent shadowing exposure during college. And that's hard to do, again, right? If you don't know any doctors, you don't have any family friends that are doctors that could like maybe put you in contact with people. So what I did honestly was I went online and I searched for doctors in the area. At the time, I wanted to be an OBGYN. So I was looking for OBGYNs that were in Atlanta. And then I would just like email them, or I would call the office and just ask if they were like open to shadowing or having students shadow with them. A lot of the answers were no, but all I needed was one doctor to be like, yes. And so I got one that I was able to shadow throughout college, who was wonderful. And she took me with her to the OR for C-section. She kind of took me everywhere with her, to her clinic. So it's really just about finding one good person. You don't need to have 5 or 6 different doctors that you're following, but as long as you have one that's open to actually taking the time to teach you and allowing you to be with them, that's really all you need. So don't be afraid to reach out, to just email people. They're used to having students or people kind of contact them wanting to shadow. So if someone tells you no, then that's fine. Just go ask the next person. At the end of college, so I did ROTC while I was in college. And so I didn't have a lot of free time. So college was a lot for me. So I did not, at the end of college, I was not ready to apply to medical school. Like nothing about my application was saying, yes, you're ready. But I applied anyway, because I'm hard-headed. And so I was like, it's all right, I'm just gonna try. I took the MCAT, I did average on it. I was like, that's good enough for me. And so I applied to places, I got a couple of interviews, but I did not get in my first time. I was upset about it, but I was like, Jasmine, you can't really be surprised because you did not put your all into the application. It was kind of I felt like I had to go straight into medical school out of college or I was a failure, which is not true. So I ended up just taking a year between college, and during that year, I worked on my application. I did a little bit more shadowing. I just worked in general to make money, and then I reapplied during that next cycle. Ended up getting in at a school that I didn't even apply to the first time. Ended up loving it. It's the University of South Carolina in Greenville. Loved it. Did my 4 years of med school there. And then from there, ended up here in Arizona for my residency training. And so depending on what you decide you want to specialize in medical school, which you usually need to make that decision by the end of your 3rd year of medical school, because 4th year is when you will start applying to residency programs. So depending on what specialty you choose, your residency will be anywhere from like 3 to 5 years. So for pediatrics, it's 3 years. And then for general surgery, I think it's 5, and then neurosurgery is like 7. So it just kind of varies. And then at the end of residency, you have the decision to either go out and start working. Like I could, now when I finish in June, I could just start working as a general pediatrician, but that's not what I want to do. I knew that I wanted to be a pediatric oncologist. And so during this last year is when I did the application cycle for fellowship training. And fellowship is really what you call anything after residency that you do to become even more specialized within your field. And so I went through the whole match process again and ended up matching at St. Jude. And so I'll be starting there in July, and that will be another 3-year program. And then once I'm done with that, I'll be done with training finally. It's a very long process, but worth it in the end if you know why you're going into medicine.
So is there anything like other than maybe like shadow experiences that if we can find any like in high school, is there anything you would recommend, maybe like volunteering at a hospital, joining any clubs, stuff like that? Yeah,
I think all of that's definitely good. And I would say also, you don't have to do like your volunteer activities don't necessarily have to be medicine. They could be really anything that you've shown a commitment to. I don't recommend having like 4 or 5 different things that you're volunteering with, because people just want to see that you're actually like committed to like a couple of things that you actually do long term, instead of like 5 kind of short volunteer experiences that you do. So I would say you can volunteer at a hospital, you can volunteer at an animal shelter, you can volunteer at whatever interests you. It doesn't have to be medicine. And I will say in med school, I got involved with the Make-A-Wish Foundation because my brother had a wish granted through them, and I fell in love with it after that. And so I've been working as a wish granter through them as a volunteer, just kind of helping make other wishes happen for other kids. And so that's something fun I would recommend if anyone's interested in doing that. It's very easy to do. I do think you have to be 18 and above. So something good to do during college time that's not time consuming, that would be good. And you would get exposed to a lot of different medical kind of conditions through that as well, through the kids that you have. But volunteer in anything that you want, just make sure that it's something that you're doing consistently and it's not just kind of one and done. And that's really it. It doesn't have to be medicine. Even when you go to college, you don't have to major in biology. You don't have to major in chemistry. It doesn't have to be a science major. There were plenty of people in my class that majored in Spanish and art and history. You would just have to still find a way to take the science classes, but don't feel like you have to major in something super sciencey to go into medicine.
Okay, thank you so much.
Mm-hmm.
All right, and Varisha, would you like to go?
Yeah. I was gonna ask, have you personally ever worked in plasma oncology? Because I heard it is like more of a newer method of treatment.
Say that again. I couldn't hear. Sorry.
Have you ever worked with plasma oncology?
Plasma?
Yeah.
I have not. I'm actually not sure what that is.
Plasma oncology. I heard it's like a newer treatment.
It might be. If it's sounding like it might be something like a plasmapheresis type thing, where they kind of take your blood and replace it with new blood that doesn't have like the antibodies or the cells in it. That's what it sounds like, but I've actually never heard of that term, kind of plasma oncology.
Oh, okay. Thank you.
All All right, I guess then next, Lizette.
So I'll be doing pre-med in the fall, and I'm a bit nervous about it, but so do you have any advice for mental or just like, because I know you said to be more involved in sticking to services and shadowing, but is there like any other advice that you would give specifically to those who are going to be doing pre-med?
I would say, it's hard. College is meant to be fun, right? But as pre-med, you don't really get to have that much fun because it's a lot. It's very rigorous. Your friends are going to be doing other majors. They're going to be going to all the parties and having all the fun. It's going to take a lot of, and it's good. You want to party sometimes, right? But you have to have a lot of discipline and kind of just have that motivation and know why you're doing what you're doing so that you don't get too caught up kind of in the hype of college. Still enjoy college, like go to a party or two every other weekend or so, but like you really have to kind of hunker down and focus on your classes, on your grades, because it will all matter ultimately when you get to the point of applying for medical school. So I think that's the hardest thing during college, being a pre-med, is because you're young, you're finally kind of free, and you want to go and just enjoy yourself. And it seems like everyone else is because everyone else, most other people are not pre-med. So it's just a matter of balancing that out. I still want you to enjoy yourself. I still have fun in college, but you just have to know, like, you can't do what everyone else is doing all the time.
Okay, thank you for the advice.
Yeah, no problem.
I think that's great advice too. As someone who's very involved in Greek life, there's definitely time to study and there's definitely time to go out.
Oh, yeah. I also pledged in sorority to college. So it's all doable, but you just have to kind of, balance it out.
Wait, what sorority were you in?
I pledged Delta Sigma Theta.
Oh, that's really cool. I'm in Alpha
Okay.
Chi. All right. Haritha, would you like to go? Last raised hand question.
So you said that we could continue with medicine without majoring in it. So how would one go about doing that?
Yeah, so had I known this when I was doing college, I wouldn't have majored in biology because I hated biology. I would have majored in like math, or I would have majored in Spanish. But you can choose any major that you want and still consider yourself on a pre-med track. Again, that's where kind of being involved with with the like pre-med or pre-healthcare professions kind of program at your school is important, because they will direct you as far as like, well, what science classes do I need to take to prepare myself for the MCAT? What do I need to have, on my transcript in order to be a successful applicant for medical school? So that kind of part of it will kind of be managed, or you'll get help a bit with that from like a career counselor or someone within kind of like the pre-med office. Because the only upside of majoring in a science is that you'll just take those classes no matter what, because it's a part of your major. But if you major in something else, you'll just have to fit in those science classes within kind of your actual major classes, if that makes sense. So that you still have the knowledge base to take the MCAT and to also get into medical school, if that makes sense.
Yeah, so would that take more time balancing major and then the medicine?
No, it should still take the 4 years. Some people take more than that, but it doesn't have to. You can get all of that done within, because the classes that you would take wouldn't be, because when you major in a science, right, you take like majority of your classes are just science classes, but you don't need all of those to succeed on the MCAT or to get into medical school. So when you're majoring in something else, you usually take just what you need to get the material, to understand the material and pass the test. So it's still within the same time frame. It seems like it's extra work, but it's not really, if that makes sense.
Thank you.
Mm-hmm.
Yeah, as someone who's majoring in global management and business, it's completely possible.
Yeah.
And then I guess we'll go to chat questions. These are going to be pretty quick. Okay. It's okay, I can read them out loud, no need. And then, okay, so someone in chat asked, in the lymphoma picture that you showed, is the black spot part of the lymphoma?
Let me go back and see. Which black spot? Is it kind of all the way around here?
She said the lower one.
Whoops. Like here? Oh, okay. Oh, I did it again. No, so this is actually like a bowel, like bowel gas. So you're just seeing kind of gas within the bowels here. And then all of this black stuff back here is lung tissue. And then everything black that you're seeing is basically air. So that's why the lungs are all black, because there's just air in there. And then you have a little bit of, looks like a little air bubble there in the gut and the intestines. And then this is your trachea leading into your lungs. And so that's why this is black as well. It's just a sign that there's air. At least on a chest x-ray, every imaging study is a little different.
All right, sounds good. And then another question was, would you use the term like cancer cure if the cancer is likely to return?
So that's a good question. So we usually use the term it's in remission, which kind of can synonymously mean cure. But we say remission because we do know that there's a possibility that it can return, or a patient can relapse is the word that we use. And so that's why these kids get monitored routinely, usually monthly, and then it kind of spreads out. The longer they've kind of been disease-free, the kind of more spread out you have the follow-up visits, but you follow them very closely because there's always that chance, and families get counseled on that from the beginning, that even when kids go into remission, that's great. It's a good sign that they responded, but sometimes they can have a relapse. So we do use them synonymously. But a true cure, usually we say if they're 10 years is usually the mark, where we're like, after that, they're considered to be cured. But I usually like to say remission because it's not so much of a final kind of term to use as far as their cancer goes.
And then our last question is from Lila in chat. What was your stats of getting into medical school? She said she's always wanted to become a pediatric oncologist, but she's worried about getting attached to a kid and then they pass away.
Oh.
Do you have any advice for this? And thank you for answering everyone's questions.
Yeah, no problem. What was that first part? It was something about stats.
Yeah. What was your stats of getting into med school? So
Okay.
maybe just your GPA and MCAT.
Yeah. So my stats weren't the best. I had, what was my GPA? Gosh, I want to say it was probably like a 3.3. My MCAT score, they score it so differently now, but at the time it was like a 25, 26, and that was like considered average. Above average, I want to say was like 30 and above or something like that. So I had, bottom line, I had very kind of middle of the line kind of average scores, like they were enough, like they were high enough to say, okay, we'll actually look at your application, but they weren't like stellar to where, the scores were going to carry me and I was just going to get all these interviews. I would say the biggest thing I think that carried my application was my community service. It was kind of my other things that I did outside of medicine that they were really interested in talking about. I mentioned I did ROTC, so I was in the military. And so a lot of the things we talked about in my interviews were not about medicine. And then of course, my brother was always a talking point. He was in my personal statement for med school, personal statement for residency, clearly my personal statement for my fellowship. So that was always a talking point. That's why it's important to have those things outside of medicine. That's why I said when you volunteer, it doesn't necessarily need to be medicine, because they like to hear and see that you're doing things other than medicine. They like to know that you also have a life outside of medicine. So I think a lot of what carried me was my extracurriculars, the other things that I did, and not necessarily the grades. Like the grades kind of got me through the door, but like I think the actual stuff that I was doing outside of medicine is what kind of put me over certain people when it came to the interview, because I know plenty of people that were 4.0 GPAs, top-notch MCAT scores, that were just not good people, if that makes sense. So you can be really smart, get all the good grades, but if you're not personable, if they can't see that you actually have spent time in the communities, you do have this kind of deep yearning to be a doctor for reasons much deeper than just being a doctor, then that really does shine more than just having kind of the higher grades, because it takes a lot more than that to be a good physician.
And lastly, in chat, Carolina asked, what exactly did you do in the military and how long were you involved in it?
Oh yeah, so fun story. So my mom was in the Army. She retired a few years ago, but as I said, I went to Spelman College for college, and it's a private school and it's expensive. And so after my first year of college, my mom basically gave me an ultimatum, and she said, either you go to a public school in Georgia, so I could have gone to like University of Georgia for free because of my GPA through their Hope Scholarship. She said, either you do that or you join the military and have them pay for school. So I was stubborn, and I was like, I don't want to go to any other school. I only applied to Spelman because I'm like, that's the only school I want to go to. So I wasn't leaving, so I joined the military. I do not recommend making decisions that way. So I joined the military, and I took the fall semester of my sophomore year. I went a few months away and did basic training and advanced individual training. And then I came back in the spring of my sophomore year, joined ROTC. That also made college hard for me because I missed a whole semester. So I kind of had to like play catch up because I still wanted to finish in 4 years. But having ROTC on top of that made it so much harder. But I got through it. I got commissioned as an officer when I graduated from college. And then at that time, I was actually considered a military police officer. That's what I trained in for basic training and everything initially. Once I got into med school, I was able to switch to at least a medical field. It still wasn't like what I wanted, but it was the medical field. And so I would go to trainings once a month and then 2 weeks in the summer with whatever unit I was a part of for the military. And then my ultimate goal right now, I'm not doing that. I'm kind of on a hold status, but my ultimate goal is I do want to get back into the military, but I want to do it as a doctor and not as what I was doing before, because it wasn't quite a doctor. It was medical, but it wasn't what I wanted. So I do recommend that for people who are interested in the military, thought about the military. They have a lot of good incentives for medicine as far as paying for college, paying for medical school. One of my close friends from medical school did it's called the HPSP scholarship through the Army, and they paid for all of medical school. She has no loan, she has no debt. They pay for your board exams, which are really expensive. And so she's actually at Fort Bragg in Fayetteville right now doing her OBGYN residency. So it's definitely an option. It definitely helps me stay where I wanted to for college, even though I hated it. But it's an option. It's not something I would do just for the money. But if you already kind of have an interest in the military, you're interested in kind of living that life, then it's definitely something to look into to help you pay for everything.
All right, and then I guess last question we'll take, and then we can take a group photo with everyone. From Haritha, how do you deal with the loss of a patient?
Good question. It's definitely different for everyone. I will say for me, it's hard to answer. So I had my first patient die during residency, my second year of residency. It was a hemonc patient. And he was in hospice, meaning that he wasn't receiving treatment. They were just kind of preparing for him to pass away. He was doing that at home, but then he started kind of doing the things that patients do when they're about to die. The breathing changes, they become less responsive to you. There are a lot of different signs that kind of let you know that a patient is passing away. And so the parents, they freaked out and they were like, I don't want to do this at home. I'd rather him, die here in the hospital with all these people around, so that it wasn't just them at home. And so they brought him in, basically just for him to pass away in the hospital, which happens often. And it was triggering for me because my brother passed away. Like he went in hospice. So he passed away at home. He passed away in his bed with my mom and I next to him. And so it was a similar kind of thing where he was, the patient was having what we call agonal breathing. And when patients are passing away, they kind of start having this, they kind of start breathing slowly and kind of gasping. And it almost sounds like they are like losing air, like they're trying to breathe, but it's kind of a normal sign that they're passing away. And so the family, with every kind of little thing that happened with him, they would ask a lot of questions. And so, I would try to explain to them, like this, this is a natural course. This is normal what he's doing. He's not in pain. And, at that point, we usually have them on pain medications. We usually take them off of the monitor. So we're not even looking at their vitals because it's going to start, going down. And so in that situation, it was hard. It was very hard to control my own emotions. I had to really fight to not cry because my goal is to never be more emotional than the family, because then that's a lot, right? So in my mind, I kept trying to tell myself, like, you can't start crying. But every question they asked, it reminds me of my brother. So I'm like, well, and I would tell them, like this happened. My brother did the same thing at home. He died at home, and this is the same, this is the same process that he went through, to kind of comfort them and saying, like, this is normal for what's about to happen. So it's hard. After that, I definitely started bawling, and my attending, who was like the supervising doctor, she already knew that the whole thing was extra sensitive for me because of my brother, but I definitely have had moments, when patients have died, where I've had to like literally talk myself into not like just bawling. Families, they like to see I don't think they get upset if you're emotional with them, but my goal is to never like overshadow their experience with my own emotions because of my experience. And so I try to show emotion, but not take that moment away from them. And so after every patient that's died since I've been in residency, afterwards, I've like lost it in like the call room or in like the bathroom. And then you just kind of get yourself together. You go back out there because you have other patients to take care of, right? So it's hard. And I think the day that it's not hard, or the day that you don't feel anything, is when you probably shouldn't be taking care of those patients anymore, because it's just a human thing, right? Like you're always going to have those feelings. It's never going to get easier. But you have to learn how to take care of yourself after those moments happen. What you do kind of after that to kind of pick yourself up is really what's important, so that you can keep going and keep doing what you need to do to take care of, all of your other patients, but also making sure to take care of yourself. So I think everyone handles it very differently, but for me, that's my thought process when I kind of have a patient that passes away.
Wow, thank you so much for sharing your experience and coming today.